Welcome back. I am a medical doctor taking care of critically ill patients with COVID-19 with a successful management of them in the intensive care unit. This is the fourth video out of 10 of COVID-19 series. Welcome to the Medicine Essentials. COVID-19 clinical features. Incubation period. The exact incubation period is not known. It is presumed to be between 2 to 14 days after exposure, with most cases occurring within 5 days after exposure. Age affected. Mostly middle-aged, greater than 30 years, and elderly. Symptomatic infection in children appears to be uncommon, and when it occurs, it is usually mild. Sex affected. Mostly male with 60% and female 40%. It is important to describe the spectrum of illness severity. Most infections are self-limiting. COVID-19 tends to cause more severe illness in elderly population, or in patients with underlying medical problems. Worldwide, mild illness was reported in 80% patients. Severe illness in 13%. Critical disease was reported in 7%. Overall case fatality rate was between 6.6%. Let's talk about symptoms and signs. The systemic symptoms of COVID-19 are fever and fatigue. Respiratory manifestations are predominant. These are dry cough, dyspnea, rhinorrhea, sputum production, hemoptysis, and in severe cases pneumonia, and acute respiratory distress syndrome. Cardiovascular manifestations can worsen the disease. It has been observed acute cardiac injury and shock. Less common symptoms are digestive, diarrhea, vomiting, anorexia. Another problem observed in severe cases are acute kidney injury and kidney failure. Other symptoms that can be present in mild to severe cases are malaise, headache, muscle pain. The three primary symptoms of COVID-19 are fever, 83 to 99%, dry cough, 59 to 82%, and dyspnea, 31 to 40%. Less common symptoms are muscle pain, 11 to 35%, anorexia, 25 to 35%, malaise, 27 to 32%, sore throat, 28 to 34%, nasal congestion, 17 to 23%, and headache, 29 to 36%. Laboratory findings. Laboratory findings are described from a study of 200 patients. White blood cell findings are leukocytosis in 21% or leukopenia in 17%. Lymphopenia is commonly seen. Some patients had anemia, but most patients had a normal hemoglobin, and plateletpenia can be found in 13% of the patients. Alanine transaminase, creatinine, lactodehydrogenase, creatine kinase, and ferritin are elevated in patients with COVID-19 in a different amount of percentage. Prothrombin time is less than 16 seconds in 94%. D-dimer can be elevated in 42% of patients. High-sensitive cardiac troponin I greater than 28 nanograms per milliliter is a marker for acute cardiac injury in COVID-19 patients. Serum procalcitonin. Serum procalcitonin is often normal at the time of admission, however it increases in patients who require intensive care unit. In one study, high D-dimer and lymphopenia are associated with poor prognosis. C-reactive protein. COVID-19 increases C-reactive protein. This seems to track with disease severity and prognosis. In patients with severe respiratory failure with a normal C-reactive protein level, an alternative diagnosis should always be thought. Patients who meet the criteria for suspect cases should undergo testing for SARS-CoV-2 and also respiratory pathogens. Radiologic findings. In this section, we are about to describe the imaging features in COVID-19 infection. Chest radiography or computed tomography are not recommended to diagnose the COVID-19 infection. The findings on chest imaging are not specific of the infection and could overlap with other entities, such as influenza. There are also recommendations about the performance of the chest radiography, including the fact that it is better to avoid the movement of the patient within the hospital. Chest radiography. The findings on chest radiography are not specific, and in the initial phases of the disease the studies could be normal. The most common features include lobar or multilobar bilateral lung consolidation. The first chest radiograph is of a male, 70 years old, with dry cough and fever. On arrival to emergency room, oxygen saturation was 89% and had lymphopenia. Bilateral ground glass alveolar consolidation, with peripheral distribution. This case shows how fast COVID-19 can progress, with typical radiological findings of patchy, bilateral alveolar consolidations, with peripheral distribution and ground glass density in early stages. The second chest radiograph is of a male, of 75 years old, presenting with fever and cough. The third one is of a male of 55 years old, who had 6 days self-isolating with fever. Progressive respiratory effort. Lymphopenia was observed on presentation. Computed tomography, CT chest. Recent studies have reported the features on CT imaging. It is described 4 stages. Early stage, 0 to 4 days after the onset of the symptoms, in which ground glass opacities are frequent, with subpleural distribution, and involving predominantly the lower lobes. Some patients in this stage could have a normal CT. Progressive stage, 5 to 8 days after the onset of the symptoms, the findings usually evolve to rapidly involvement of the 2 lungs or multi-lobe distribution with ground glass opacities, crazy paving, and consolidation of their spaces. Peak stage, 9 to 13 days after the onset of the symptoms, the consolidation becomes denser, and it was present in almost all of the cases. Other finding was residual parenchymal bands. Absorption stage, greater than 14 days after the onset of the symptoms, no crazy paving pattern was observed. The ground glass opacities could remain. Chest computed tomography scan has been widely used to further assess patients with COVID-19. Early evidence suggests that initial chest computed tomography shows an abnormality in at least 85% of patients, with 75% of patients having a bilateral lung involvement that most often manifests as subpleural and peripheral areas of ground glass opacity and consolidation. The cord scan is of a male. He is 70 years old. Recent travel from endemic COVID-19 region. He presented with 24 hours confusion with high temperature and desaturation on assessment. On axial and coronal imaging can be observed multifocal regions of consolidation and ground glass opacifications. These have a peripheral and basal predominance. No pleural or pericardial effusion. Now let's talk about case definitions. Suspected cases are 1. A patient with acute respiratory tract infection, sudden onset of at least one of the following: cough, fever, shortness of breath, and with no other etiology that fully explains the clinical presentation, and with a history of travel or residence in a country or area reporting local or community transmission during the 14 days prior to symptom onset. 2. A patient with any acute respiratory illness, and having been in close contact with a confirmed or probable COVID-19 case in the last 14 days prior to onset of symptoms. 3. A patient with severe acute respiratory infection, fever, and at least one sign or symptom of respiratory disease, cough, fever, shortness breath, and requiring hospitalization, and with no other etiology that fully explains the clinical presentation. Probable cases defined as a suspected case for whom testing for virus causing COVID-19 is inconclusive, according to the test results reported by the laboratory, or for whom testing was positive on a pan-coronavirus assay. Confirmed case: a person with laboratory confirmation of virus-causing COVID-19 infection, irrespective of clinical signs and symptoms. Close contacts. Close contact of a probable or confirmed case is defined as a person living in the same household as a COVID-19 case, a person having had direct physical contact with a COVID-19 case, like shaking hands, a person having unprotected direct contact with infectious secretions of a COVID-19 case, being coughed on, touching used paper tissues with a bare hand, a person having had face-to-face contact with a COVID-19 case within 2 meters and 15 minutes, a person who was in a closed environment, classroom, meeting room, hospital waiting room, etc., with a COVID-19 case for 15 minutes or more and at a distance of less than 2 meters. A healthcare worker or other person providing direct care for a COVID-19 case, or laboratory workers handling specimens from a COVID-19 case without recommended personal protective equipment, or with a possible breach of PPE. Clinical course. The clinical course was described in a study. Median time from illness onset to dyspnea was similar in survivors and non-survivors, with a median duration of dyspnea of 13 days for survivors. In survivors, the median duration of fever was 12 days and cough persisted for 19 days. 45% survivors still had cough on discharge, and 72% non-survivors still had cough at the time of death. Sepsis developed at a median of 9 days after illness onset among all patients, followed by acute respiratory distress syndrome, 12 days, acute cardiac injury, 15 days, acute kidney injury, 15 days. The median time from illness onset to discharge was 23 days. The median time to death was 18.5 days. The median time from illness onset to invasive mechanical ventilation was 14.5 days. Extracorporeal membrane oxygenation was used in 3 patients, none of whom survived. Sepsis was the most frequently observed complication, followed by respiratory failure, acute respiratory distress syndrome, heart failure, and septic shock. Half of non-survivors experienced a secondary infection, and ventilator-associated pneumonia occurred in 31% of patients requiring invasive mechanical ventilation. The frequency of complications were higher in non-survivors than survivors. This is everything for the 4th video. Thanks for watching. There are more videos you have to watch. I will be talking about specific diagnosis for viral infection detection in the next video.